So my pleasure to introduce Amber Baskin. We've worked together now for the past few years. She's Senior Program Coordinator for our Enterprise Melanoma and Cutaneous Oncology Research Program. She has a decade of experience working directly with research subjects and managing clinical trials. She joined Mayo Clinic in 2018, supporting our neuroscience research unit. We were able to steal our way from all that stuff, transitioning her to oncology and the Mayo Clinic Comprehensive Cancer Center in 2021. Amber.
Okay. Thank you, Dr. Jacob. I have to say I was kind of nervous this morning and connecting with you all. I've been working remote for the past number of months and I'm still a little nervous, but just connecting with you all face to face. Some of you I already knew and some of you I talked to for the first time, but you have directly contributed to my presentation by helping me relax. So here we go. So we're going to talk a little bit. I'm going to give a brief introduction to research and clinical trials because some of you have never been involved in them. So I think it helps to understand some of the steps. We'll talk about some common myths because these are very valid concerns that patients who have never had any exposure to research have. So I think it's fun to talk about some of those. And then we'll get into the fun stuff and talk about the exciting things that our researchers are doing. And then I just want to share some resources. So Dr. Dranka touched on this and maybe some of the other talks did as well, but it's important to remember that all currently available treatments were once clinical trials. That's always the first step. And Dr. Dranka also touched on this and maybe some of the other talks as well. But prior to 2013, the melanoma mortality rate was very high. And one of the things that contributed to significantly reducing that rate, particularly between 2013 and 2017, was the introduction of new treatment options, such as immune checkpoint inhibitors and targeted therapies. And that was made possible because of research. And even though we've met such a huge milestone with those treatment options, more research is still needed. We still need to learn more about melanoma and ways that we can better prevent, detect, and treat melanoma. So every clinical trial is different. And some of the steps might apply to some of our clinical trials and not to others. But this is kind of a typical experience with research. You might start with an enrollment visit. And that might involve a conversation between you and your care team and maybe a clinical research coordinator that will go over all the details of the study with you so that you know what to expect and can make a decision about whether or not you want to participate. And then you might have a screening visit. And the screening visits can sometimes include things like maybe a blood draw, maybe a physical exam with your doctor, maybe a scan. And these are just done to make sure that this is the right treatment for you, similar to what you would do before starting any treatment regimen. The next step is the participation phase of the study. And this may be as simple as just sharing some of your experiences with melanoma or your medical history with us so that we can learn more about it through your experiences. It could involve providing a blood sample or maybe a tissue sample if you're already having a procedure, or you might be receiving an investigational treatment or surgical intervention. And then particularly for those studies that are some sort of intervention for you, there might be a follow-up period. And that's just because we want to learn not just how you do while you're receiving that treatment, but we want to learn how you do in the long term as well, because that's just as important as how you do while you're on treatment. So some common myths, or these are just concerns that in my years of working with research patients and talking to them for the first time, these are some of the concerns that they have. And these are really valid concerns. So I think it's fun to talk about them as a group. Everybody's probably heard this one. I don't want to be a guinea pig. And this just comes from the fear that we don't know anything about these treatments. But the reality is that these treatments go through a lot of preclinical testing and research before they're ever administered to humans. And all of that research is collected and presented to our regulatory and scientific authorities, many different kinds, and all of that is reviewed. And even though these are not FDA approved always, the FDA does give us permission to use these treatments in clinical trials, and that's after reviewing all of that preclinical information. It tells us things like how this drug works, how it interacts with cancer, what types of side effects you might experience, all of those things. And even though we don't know everything, we know more than what we sometimes think. This is another one. Research treatments are only for people who have failed all other treatments, and they're not. There are research studies that you can participate in with all stages of cancer or with melanoma. And there's all different types of studies. Like I said, you might just be providing a blood sample and medical history, and that's really important in helping us learn about melanoma, or you might be receiving an investigational treatment. And for patients with metastatic melanoma, clinical trials are actually considered the best option for treatment for those patients. Research treatments are more expensive because they're not covered by insurance. And while it's true that some research treatments are not covered by insurance, research studies are designed to not create additional financial burden for patients. So some of the things that patients might be responsible for would be things that they would have done even if they weren't participating in this clinical trial. But the things that are being done just for the research study, those are going to be covered by the research study in almost every case. But all of these details, billing details, what your insurance will pay for, what you'll pay for, what we'll pay for, those are things that are reviewed with you in detail before you enroll in a clinical trial. This, I think, is the last one, but research is not clinical care. Sometimes people think we're kind of siloed, and you have clinical care over here and your care team and your doctors, and then you have research over here. And if over here they can't help you, then you come over here. And that's really not the case. We work very closely. We're all part of the same team. And your treatment team, your care team, is going to consider all treatment options when presenting options to you, both investigational options as well as standard of care options. All right, so let's get to the fun stuff. What are we working on? This has probably been mentioned in a few talks already, and some of you are very familiar with this program, but our Cancer Care Beyond Walls program, Dr. Dranka and her team are working very hard to try to reduce the cancer burden for patients as much as we possibly can, because we know that the burden goes well beyond your clinical experience with cancer. There's also financial toxicity, time away from work, time away from family, time away from your home, time sitting in clinics and waiting rooms and just waiting for things to happen. And we're really trying to give some of that time back. So I have a video that explains it better than I could possibly explain it. And hopefully it won't play a commercial. If it does, it'll be brief, and I apologize.
No one does food like Puerto Rico, whether it's a chef tasting menu or a local favorite spot with no sign above the door. You'll taste the
Cancer is a life-altering diagnosis because of the diagnosis and the consequences, but also because it really takes over your life for many months, and for some patients for the rest of their lives.
What we have realized is that as cancer care becomes more complex, it becomes more fragmented, and patients end up spending far more of their time burdened by our medical tests and our treatments. And while that's good in terms of advancing the science, what we've realized is that that has a great detriment on patients' quality of life and the time that they have to spend uninterrupted or undisturbed, where they feel less like a patient and more like a human. Cancer Care Beyond Walls is a platform that allows us to safely and effectively administer chemotherapy in patients' home. It allows us to be able to reach those patients where they live, where they are comfortable. That really makes a huge difference in patients' lives.
When they put me in this program that you can do this at home, would that be your choice? And I jumped on it and said, let me be the first to do it.
I couldn't be any happier. My quality of life is up here. I'm able to be with my sister. It's just such a convenience that I could go walk, check my time. Okay, my nurse is going to be here at 9. Pop in, get my chemo, my infusion, and then I go back out and continue my walk. It's been a convenience, is what it is.
This program of getting your chemotherapy at home has changed my life. As a PE teacher, I don't have to miss school days anymore. With this program, I can teach without worry because the whole staff comes to your home. It frees up my time and allows me to do things that I never thought I would be able to do again. I feel so great. My quality of life has changed significantly to a point where I never thought I'd be.
Being on this path that we're on right now, where being stable and being able to be right here at home and being able to do all the things that we've been talking about doing and actually going to do them, being able to look forward to things after going through the times where we didn't think he was going to make it, to going to plan vacations and futures, and it's just exciting and wonderful, and it's awesome.
The goal that remains the most important for us is actually to be able to offer care to patients who do not have the ability to travel, who do have significant barriers, both financial barriers or time barriers, to be able to bring the care to those patients, to be able to decrease these disparities in cancer care and overall in healthcare, and to transform delivery of cancer care. Cancer care is very personal, I think, for me. My daughter, my seemingly healthy 6-year-old daughter, was diagnosed with an inoperable brain tumor. So as a mom, I've lived through it all, and I lived through what the patients go through. As an oncologist, I was convinced that we can do more. As a mom, I would have given everything, even if a few blood tests were done at home and we would not have to travel, even if 1 in 5 infusions were done in the home and we would not have to go through all of this. After my personal experience and after my daughter losing her battle with this disease, I'm even more determined that I will fight it with everything I can. I will fight it by changing the way we deliver care and making it more comfortable for our patients. And I won't stop until we cure cancer.
All right, there's a very small space for the mouse, so.
Cancer is a life.
I just escape out of it. How do I get back to my slides? Oh, I think we're back. Nope. So this program right now is being done through research. And I think it's important to highlight it because when we think about research, we think about treatments, or we think about, studies being done in the lab setting, but we're doing research in so many different areas. These patients are all receiving the same treatment they would receive if they were not participating in the Cancer Care Beyond Walls program, the same drug regimen, the same, they're getting their labs drawn, they're having a visit, they're doing all the same things they would be doing. We're just coming to them. So not all research is treatment related or lab based. Some of it is just looking at better ways to deliver care. And currently there are 84, although I did this a week ago and there are more patients now. So maybe it's closer to 86 or 87 at this point, but patients who have either been treated in their home or are currently being treated in their home and receiving their cancer care at home. And I want to also highlight that though we focus on treatment with this program, it's not just a treatment regimen. These patients are also receiving supportive care in the home, and they have 24-hour access to Mayo Clinic. We hope not just to reduce the cancer burden, improve their quality of life, but we hope to also intervene sooner if they do have adverse events or they do have drug-related reactions. There's so many goals with this program. I could talk all day about it, but I can't because I only have 25 minutes, so I'm going to move on. I wanted to also talk about some of this research is being done in Rochester, but there's still ways to participate, and we're doing similar research here. But Dr. Block and Dr. Weil are working on vaccine research for patients with BRAF mutated melanoma. BRAF is the most commonly mutated gene in melanoma, affecting nearly half of melanoma patients. And they have found that the vaccine activates T cells that respond to mutated BRAF, and they're testing whether the vaccine improves control of BRAF mutated melanoma. So this is one area of research that many of our teams are looking at. Whole body imaging. This is something that's going on too. And again, I have a video to share this information better than I could possibly explain Dr. Deemer's work, but him and his team are working on this, and we hope to have similar technology here in the future.
The 3D skin imaging clinic utilizes a device called the Whole Body 360. It's essentially a walk-into pod with 92 high-resolution DSLR cameras, and they're positioned in a way to capture all angles of the body's skin surface within less than 1 second.
After that, it generates a 3D avatar, and that's when the clinician goes ahead and takes a look to see if there's any concerns on the patient's body.
The software uses artificial intelligence that essentially selects any lesion that's greater than 2 millimeters. And those lesions can be either reviewed visually or captured and selected and viewable in a cluster diagram to help really identify those lesions that are standout and may require more dedicated attention in the room.
If there's concerns that the doctor's worried about, I go in and take additional photos and dermoscopy. Dermoscopy is a microscopic lens that captures in depth of what we're looking at on the lesion. And so then after that, on the patient's next visit when they're back, we're gonna match those photos to see if there's any changes and then do their 3D imaging again.
At subsequent follow-up visits, the 3D avatar really becomes most helpful because it essentially acts as a time machine where we can look back in time at an individual lesion or lesions throughout the body to look for new presence, growth, change, or evolution. As a medical student, you're taught the ABCDEs of melanoma: asymmetry, irregular border, atypical colors, diameter greater than the head of an eraser, and E is evolution. And never before have we really been able to assess for evolution outside of asking the patient, hey, is this new, is this growing, is this changing? And now with this technology, we really can delve into the E of the ABCDEs to identify those lesions that truly are changing or evolving. And we can have reassurance that those lesions that are unchanging are truly stable over time and can be monitored safely.
The WB360 benefits the patients in a lot of different ways, especially if patients have had a history of melanoma, psoriasis, or lymphoma.
Skin cancer is the most common cancer in humans. In fact, there are more cancers of the skin diagnosed every year than all other cancer types combined. We know that the earlier we catch skin cancers, the better the outcomes. And the software that we have allows us to really identify the lesions that are becoming or on their way to becoming skin cancer at the very earliest stage. In our practice, we've seen not only a decrease in the number of benign biopsies performed by using the software, but also an absolute increase in the number of skin cancers that we're finding. About a 20% increase in skin cancer diagnosis and a 20% decrease in the number of benign biopsies. The 3D skin imaging model aligns very well with the Bold Forward mission to cure, connect, and transform. Our hope is that by leveraging the high-resolution images from this platform, we may be able to identify those patients that truly need a face-to-face in-person evaluation or biopsy, and those that can be monitored safely at a distance.
Jean, I might need your help getting back again. Yeah, so if you're like me and every time you go to the dermatologist, it's a gamble. If you'll have 2 biopsies today or 3 or maybe none, maybe you'll get lucky. I think this technology is something to look forward to because it really hopes to reduce the amount of unnecessary biopsies you have without compromising the ability to detect melanoma. Oh, there we go. Thank you. Okay, I also wanted to talk about some work being done in uveal melanoma, because as we know, uveal melanoma doesn't have as many treatment options and can metastasize rather frequently and quickly. So Dr. Dalvin and her team are using organoid models, and I'll talk about what that is in just a second, but organoid models to help researchers better understand uveal melanoma and develop treatments. So with these models, these organoid models, they can actually extract tissue, create these organoid models that are grown from a patient's actual tissue, these avatars, and they can treat that cancer outside the body the same way that they would treat cancer inside the body. And these tumors respond to treatment outside the body just like they do inside the body. And this is important because uveal melanoma, as I previously mentioned, metastasizes at a high rate, and effective treatments are limited. So the ability to test these treatments outside of the body will just help further the development of treatment for these patients and our understanding of how to treat melanoma, uveal melanoma. And that's just a picture there of what they look like. I thought it was kind of cool. Okay, and this is again a collaboration between sites. This type of work might involve providing tissue samples or blood samples. These are the types of studies that we're looking at things in the lab. So Dr. Markovich and his lab in Rochester, they're using multiplex immunofluorescence, and I'll explain what that is. It's a mouthful. But it's a technique where we can study multiple antibodies in a single tissue sample using these fluorescent dyes here that you see at the top. Antibodies with fluorescent dyes bind to specific proteins which glow under a special microscope, and that microscope is down here, this red image. And this allows us to analyze multiple proteins at once, providing detailed information. And this is just one way to learn how melanoma and the immune system interact with each other. And that will help us discover new treatments. So I also wanted to share some resources. One of the best ways to get information about research could be talking to your care team. Talk to your doctor if you're interested in seeing if there are ways that you could get involved in research. We also have a clinical trials page. You can use our mayo.edu clinical trials page to find out information about studies that we have going on at Mayo Clinic. You can also visit clinicaltrials.gov, which will give you information about all clinical trials, whether at Mayo or elsewhere. And then the Melanoma Research Foundation has excellent resources. There's videos, they have so many educational materials that I think are great. And I even use them for myself when something new comes out. I know MRF is going to have a video about it, so I can learn about it and pretend that I was ahead of it and I just already knew all about that new innovative thing. But they have infographics, all sorts of information. So you can learn more about research, but also just melanoma. If you haven't checked out their page, definitely check it out. And then I just want to close by saying some of you I've caught up with because you've participated in clinical trials. And so I already knew you today, and some I haven't. But if you have participated in research before, I just want to say thank you, because your willingness and your trust in us to allow us to enroll you in some of these trials is what allows us to move the needle forward and learn how to better care for melanoma and patients and families who've been affected by it. So thank you.